Okay, well, today we're tackling a question that affects millions. Why do I constantly feel the urge to pee? Is it overactive bladder, interstitial cystitis, or something else entirely? If urinary urgency has left you feeling dismissed or stuck without answers, this conversation with Dr. Jennifer Anger, leading urologist, expert in pelvic medicine, and vice chair of research at UC San Diego Health, will help you finally make sense of what might really be going on. So, welcome, Jennifer. Thank you so much for being here. This is an exciting topic that so many people, I think, really are quite confused about and struggle to differentiate between the two. So, this is going to be a great conversation to dive into for anyone who really is struggling to understand what's going on with their bladder and their symptoms.
Well, thanks so much for having me.
Yes. So, we can just start off maybe how do you clinically differentiate overactive bladder from interstitial cystitis?
This is a really important topic, and it is really a tricky scenario. So I'll talk a little bit about the sort of basic differentiating factors between OAB and IC, and then also talk about this sort of in between, which actually used to have an important diagnosis called frequency urgency syndrome, which was in the urology literature, but it actually got replaced with overactive bladder, or what we call OAB. But there is this definite spectrum of patients that have symptoms a little bit like IC, a little bit like OAB, that actually may fit in that old school diagnosis of frequency urgency syndrome. So, overactive bladder is defined as frequency and urgency with or without urgency urinary incontinence that occurs outside of another factor, such as a urinary tract infection. On the other hand, interstitial cystitis or painful bladder syndrome, which for this conversation we can just call IC, is bladder centric pain, which the duration has changed. It used to be 6 months, but then we would wait this long period and the patients would suffer without a diagnosis. Then it was thought to be 6 weeks, and now thinking is talking about 3 months. But regardless of if it's 6 weeks, 3 months, or 6 months, it's bladder centric pain that occurs outside of a urinary tract infection. But what's really important to note is the majority of patients with bladder centric pain have frequency and urgency, as well as painful bladder filling.
Mhm.
Um, Now, as the diagnosis of or the definition of overactive bladder was coming into play, there were discussion by our societies of including fear of leakage in the overactive bladder definition. It didn't actually make it to the definition, but it's an important concept. If someone has frequency and urgency and they run to the toilet because if they don't make it, they will leak, that is what we call like our classic overactive bladder. Whereas patients who might have painful filling, painful urgency, they run to the toilet because they are so uncomfortable with that urge. They have to get to the toilet, but they don't leak. That is more of a picture of IC.
Mhm.
But they may not actually have bladder centric pain. They may just have uncomfortable urgency. I personally treat that, what we call that frequency urgency syndrome, as being a little bit more on the spectrum of IC. However, we can also treat them with common treatments for both of those ends of the spectrum of diagnosis.
Mhm. So, a lot of times I feel, and I've heard this many times in dealing with IC and working with people with IC and having IC myself, um, at the beginning, in the initial stages, they'll go to their general practitioner with their symptoms, and their doctor, their GP, will continue to prescribe antibiotics, even though they're not showing infection. Why do doctors do this? Like, I just, it boggles my mind. This has happened to so many people. It happened to me. It happened to so many people I've conversed with over the years. And I just wonder, why are they prescribing antibiotics when there's no infection present?
That's a great question. So often I see, and I remember when I was in training, which was a long time ago, I trained in urology from 97 to 2003. But our chair, Dr. Derek Kotvon, used to talk about IC patients and say they remember the day it started. And so it's the big mimicker. It presents like a UTI. And so I think it's reasonable. Let's say they even go to urgent care. Maybe their urinalysis is negative, but maybe it's not. It's reasonable to get a urine obtained, send a patient home with antibiotics, and then wait for that culture, which, as you know, takes 48 to 72 hours to come in. And so that I think if I were an ER doc, that would make sense to me to give them empiric antibiotics as long as a culture is obtained. However, once this happens more than once, I think we start to think about IC. Or when that culture comes back negative, we should be thinking about referral to a urologist, a gynecologist, a urogynecologist. Because what we do see, like you're saying, I think it's understandable for that to happen once, maybe even twice. When the patient gets antibiotic, antibiotic, antibiotic without a positive culture, that is when we're starting to not diagnose something that we need to be diagnosing. And actually, we did a study through the VA healthcare system looking at the epidemiology of interstitial cystitis and sort of practice patterns. Patients can wait like 4 to 5 years with those symptoms the exact symptoms you're talking about, getting treated with antibiotics before they get a diagnosis. So I think it's really important um, to have that awareness that I do that if someone has one negative culture with symptoms like that, I start thinking about the pathway to IC. But I think we really do need awareness in healthcare systems to know that if a patient doesn't have a UTI, they need to be referred somewhere where they can have an adequate workup.
Mhm.
And just one more comment, it's actually worse in men. Men are often, they have chronic prostatitis, and they go even longer than women without a diagnosis.
Yeah, I'm finding that, you hear men being diagnosed with CPPS, chronic pelvic pain syndrome. When how many times would you say it's actually IC? Because it looks like we have, they're saying IC is mostly found in women, over 90% women. But is that really a true statistic when we have men diagnosed with CPPS and it might actually be interstitial cystitis as opposed to CPPS?
That's another great question, Marnie. We, there's those statistics from different studies that look as high as a 10-to-1 ratio, but as doing kind of better research, more recent research, it's as low as 1.6 women to one man, and even more recent studies show it's 1-to-1. So I think it's important because chronic prostatitis presents differently than IC. IC, again, bladder-centric pain, whereas chronic prostatitis has more symptoms related to the prostate, perineal pain, different pain with ejaculation. And so there are ways to distinguish IC versus chronic prostatitis, although again, we may treat them similarly. And actually men were treated, and this is getting better. We're getting better at all of this, but men were treated they would go on a heavy duty course of antibiotics to treat acute prostatitis. Even though they had no signs of infection, they would be treated with, like, we're talking 6 weeks of like ciprofloxacin, which has lots of side effects. And before they would be actually, before the diagnosis of a chronic pain condition was actually considered. And so I think we are getting a little bit better about not treating patients with pain, with antibiotics.
Mhm. So, what is the diagnostic criteria? Because I know now they're saying you don't necessarily need a cystoscopy to diagnose IC. How would one be diagnosed?
So really the clinical picture of bladder centric pain at least 6 weeks in duration. As it approaches 3 months, we're more certain of it.
Mhm.
Because again, you talked about those patients that might get a flare of pain, treated with antibiotics and then be fine for a while. We don't always diagnose those with IC because that is we want to give it a little more time to be certain about the diagnosis.
Mhm.
But so for IC, it really is that bladder-centric pain by history, not in the setting of a UTI, and doing a pelvic exam where we feel the bladder and identify tenderness in that when we palpate the actual bladder. Because there are other causes of pelvic pain that can be, again, mimic IC. Pelvic floor tenderness, or what we call pelvic floor dysfunction, vulvodynia, which is more pain at the vaginal opening, um, uh, other etiology like endometriosis causing some pain that could be related to the uterus or other parts of the pelvis.
Mhm.
So really physical exam. Now, cystoscopy is a useful adjunct. In our guidelines, cystoscopy is considered if a patient's not getting better with therapies like oral medication, getting enough rest, possibly avoiding triggers in the diet, even medical therapy. So if patients aren't getting better, we do like to do a cystoscopy, mostly to look for a population of patients with IC who have Hunner's lesions, which is an ulceration in the lining. It happens in about 5 to 10% of patients. It does happen to occur in patients who are a little older as opposed to the young generation of IC patients. I don't like to use that term older as I myself hit those older generations. But patients with more chronic symptoms, we do like to do a cystoscopy because if we can identify Hunner's lesions, we can actually treat those very effectively with a steroid injection. We usually do this under anesthesia, though it could be done under local, and or fulguration or cautery of the ulcers.
Mhm. Mhm. And do they often have to do it more than once, assuming they grow back, or?
They can recur. Sometimes, it depends on different patients may have more like what we call recalcitrant ulcers that come back or come back in other areas. But we usually go by their symptoms. If they're doing really well after treatment of an ulcer with steroids, we just give them time and see how they're doing. And then do another cystoscopy if their symptoms are not, come back.
Mhm. So treatment approach wise, like let's look back at OAB. Um, what are the treatment options? And can someone have both? Can someone have both IC and OAB? And how would you go about treating a patient that presents with both conditions, if they
They
can?
definitely can. And actually, a lot of patients with IC, a pretty large minority, will actually leak on the way to the toilet, which makes it very tricky. So, if patients um, have frequency urgency, either with leakage on the way to the toilet or with uncomfortable urge that drives them to go to the toilet, we often start with overactive bladder medications. Those include what we call beta agonists, which help stimulate bladder relaxation, as well as the like older school, I call it, line of medication known as anticholinergics or antimuscarinics. Those medicines block contraction of the bladder. Now, beta agonists have a little bit better side effect profile. We do monitor blood pressure in patients with hypertension using those agents because it can elevate blood pressure. It usually doesn't unless a patient's blood pressure is not well controlled. Antimuscarinics, we tend to be a little more careful with those, especially with older adults. There's an association. It's not necessarily causal, but there is an association with anticholinergics and effect on memory and cognition. They also cause some dry mouth, dry eyes, and constipation. They're contraindicated in patients with narrow angle glaucoma. But both of those classes of medication can help with the urgency frequency.
Mhm.
Um, we also, patients with leakage on the way to the toilet, if they don't respond to medication, um, and also patients with frequency urgency and IC, who don't respond to those medications are candidates for other treatments that we offer, like sacral neuromodulator modulation, like a little bladder pacemaker. There's tibial stimulation, which also stimulates the third sacral nerve root that goes to the bladder. That can be done with an office-based procedure with stimulation with a tiny needle at the ankle level. They do that once a week for usually about 11 weeks. There's also Botox for overactive bladder, which we inject in the bladder that has some efficacy in IC, probably a little better for the overactive bladder patient. But we have a lot of these third line therapies, which we can use for for both conditions. In my experience, IC that doesn't respond well to medications, um, I've had really good success with sacral neuromodulation. That is the little implant, the bladder pacemaker.
Mhm.
And so, and further studies are being performed in IC patients. So we're getting more and more data about both Botox and neuromodulation for these populations.
Okay. And can urgency without frequency or pain still be an IC diagnosis?
That's a really good question. So, especially if it's uncomfortable urgency, it might be in that spectrum. But pain is really what is diagnostic of IC. So, that might be more of an OAB patient who doesn't leak, something that is called OAB dry. So, the patient with OAB, frequency, urgency, and leakage on the way to the toilet is classically called OAB or overactive bladder wet. And then that OAB dry patient sounds more like the patient you're describing who doesn't actually have bladder centric pain.
Hmm. And what if they had, say, dyspareunia or hypertonic pelvic floor pain with, is there any way, like, is it just pain when the bladder is full that would be a diagnosis of IC, or would it be relative to the other sensations? Is pressure considered pain, would you say?
Pressure is sort of a painful sensation. We feel, patients will have heaviness. So that is sort of on the spectrum of pain. But when we think about IC, really the primary symptom is bladder-centered pain. So
Mhm.
the pelvic floor spasm, it's interesting because patients with bladder pain can get like a reactive pelvic floor dysfunction. So they will do well with physical therapy.
Mhm.
And so that's everything, it's tricky because it can all go hand in hand, right? You can have both OAB and IC. You can have IC with pelvic floor dysfunction. You could actually have all three.
Hmm. Because I always wondered about my diagnosis because I was diagnosed in 2003 through a cystoscopy with hydrodistension, and the results were that I had low capacity and pinpoint glomerations upon hydrodistension. So that was the diagnostic criteria for me to be diagnosed with IC. I just wonder, would that still be the diagnosis that I would get, or would I get that OAB dry diagnosis?
Yeah, it sounds a little bit more like that OAB dry diagnosis, but it depends on, right, like how much do you have pain? Do you have pain with bladder filling, which is sort of an IC diagnosis? That's another thing that's a little tricky too, is the diagnostic criteria like filling a bladder and seeing glomerulations. And what those are, the term comes from from a kidney glomeruli, which is a little, it's a tiny unit in the kidney that has this little appearance of like a red kind of tiny little piece of yarn, I guess you would say. And we get those when we fill the bladder usually under anesthesia. But you can overfill a bladder in a patient who doesn't have symptoms, and you might induce that, small bleeders, or what we call bleeding areas, which are called glomerulations. And so it's not 100%, it's not specific for interstitial cystitis alone. So that's a little bit tricky. And
Yeah.
same with other tests we used to do. We used to do potassium sensitivity, which seems a little mean. We stopped a lot of the mean tests that we used to do in urology. We used to put potassium in a bladder of a patient with IC. And if they had pain, then you said, oh, they definitely have IC. But like if you could induce pain from potassium in someone who doesn't have bladder pain. So that's why we really got away from some of those more strict diagnostic criteria, because they end up putting the patient through testing and not always helping diagnose it.
Are there any new or emerging tests that are coming through that can help diagnose, or is it really just based on symptoms and monitoring and
Yeah,
yeah?
I think clinical history and physical exam, and then doing the cystoscopy kind of when indicated, when they don't respond, or if they're, we suspect an ulcer. Another thing that it's not an official criteria, but something that I really think is important, is the presence of dietary sensitivity. Because it's really it's very prevalent in the IC population. One study from Dr. Moldwin and Shorter on Long Island found like 90% bladder sensitivity. And I was like, oh, it's just their patient population. And then we actually studied it among veterans across the US. And they also had extremely high like dietary sensitivity in the 70s to 80%. So I sort of think about, I ask patients who have a diagnosis of IC if they have dietary sensitivity, and see if they have like trigger foods. And that sort of, to me, helps me make the diagnosis.
Mhm.
But if they don't have bladder pain, let's say they have just frequency, urgency, and leakage on the way to the toilet, don't really have uncomfortable urgency or pain with filling, I don't usually recommend avoiding dietary triggers, although those diuretics like coffee, right? Caffeine can definitely we do recommend reducing those for OAB patients.
Mhm.
That's another thing that's tricky is patients with overactive bladder um, do well in general when we reduce fluid intake. Like we tell them, don't shoot for 8 to 10 glasses a day. Really try to go by your thirst. Or if that's sort of hard, because people really get used to drinking certain volumes of liquid, then I'll say, how about 4 to 6 glasses a day? And then not restricting any fluid when you're exercising or sweating.
Mhm.
But patients with IC often have better symptom relief when they stay well hydrated. So that's a little tricky. It's finding that balance between both, where you're hydrated, but not actually, giving yourself, the need to go to the toilet every half hour.
Mhm. Mhm. So how can a patient advocate for themselves if they feel their symptoms are being dismissed?
That is a really good question. Again, really, I think asking for a referral to a urogynecologist or or urologist, looking up interstitial cystitis specialists in your area. I think that's going to be a really good way to do that. And then asking your primary doctor for a referral to that practice, because you want someone who almost advertises as a practitioner for IC, because they're going to be more likely to know how to manage it. It's, as we know, we're not, there's theories about the cause, but we don't have a definitive cause, which means treatment's a little harder. Treatments are varied. They don't all work for the same treatment, doesn't work for every patient. So it's a tricky condition to manage. So you really want someone who has a degree of dedication to it.
Mhm. The problem is, though, there aren't a lot of urologists, and I don't know if I'm assuming it's as bad in the US as it is in Canada, but in Canada, there are few and far between. I mean, we can barely come across in Toronto, a city of, massive city, millions and millions of people, you can't find any IC specialist. So there's a huge struggle there. Nobody
Mhm.
wants to take it on, which is very frustrating for many, because they want to get the help. They want to see that specialist, but they just can't find someone to take them on.
Yeah, I know the one place where they really have a large center is it's Queens.
Yes,
What is
in
it?
diversity, it's
Yes.
in Ontario, where Dr. Nickel was practicing. He's retired now. There is another doctor who took over, but Kingston is 3 hours from Toronto, and it's a small place in comparison, and they don't usually take on patients outside of Kingston
Oh,
residents. So it's a frustrating one. Yeah, I get people asking me all the time, like, who can I see for IC? And I wish I just had a larger list to pull from.
yeah. That's
So,
tricky. In the States, we do a lot of video medicine
yeah,
across within a given state, but we're not, if we're only licensed, like for example, I'm only licensed in California.
sure.
So I want to do a video visit with someone in Chicago, but I legally cannot because I am licensed in the States. So
Hmm.
that's another barrier because you think with video medicine, it would really expand our opportunity to treat people outside our given area, but it
Hmm.
is still a barrier.
I know. I just would love to see a change there. I mean, I don't think it's going to happen, unfortunately. It tends to be these syndrome um, conditions that tend to be, they're probably the least understood out of all of them. There's not a quick fix, right? So,
So
and
true.
then they had that drug, Elmeron, that ended up, specifically for IC, then it causes retinal maculopathy. So people are not wanting to take it, right? So then there's the one drug that people could take that a lot of people had success with, but then now they don't want to take it anymore. So that brings us to supplements, which I think are extremely beneficial. Um, so tell us about the supplement that you have created with your partners.
So we're really excited about this. And we had done some interviews with patients and really found that not everyone wants to be on medication. Some patients do better with symptom management. And we have a really nice, it's 3 products within the Femetry line.
Mhm.
And one is to help sort of what we call restore balance. The idea is, as we talked about, many patients, when get treated before diagnosis of IC, treated with multiple courses of antibiotics, sometimes we need to just restore our flora. And so that is what one of our great products is to help restore that balance. The next is to help with pain, and it has a lot of really great properties that are anti-inflammatory. And these are not tested necessarily together, but tested individually. So rutin, ashwagandha, we have these really nice anti-inflammatory properties that help treat pain on a daily basis.
Mhm.
And then lastly, we have a product that helps reduce bladder acidity. So it's designed to take before a meal. And so with that combination, we found, we're currently putting these up to like a larger test with patients to kind of formally test the results of our products. But what we found so far, at least by patient report, is that it seems to be a really great combination of products. Where I had a patient who was like, um, she lived in another country. She's like, I really want to get this so I can bring it with me. It was really, we had just had some samples for her to try, and it seems to be doing really well.
That's great. That's
Our
really
goal is, it's hard because I'm come from a very Western medicine background, right? I believe in medicines, and so my own like personal bias has been I don't really um, historically, I'm not a supplement person, right? And then as I myself am approaching menopause, realizing like having trouble sleeping, you start thinking, well, maybe I should give some of these things a chance, right? And so, well, it's really neat to see something actually in practice really work for patients
Mhm.
and without side effects. Like that's what's so great about the supplements is the side effect profile is really desirable for patients.
It's true because I've been on amitriptyline for so long, over 20 years. And I worry about, the long-term effects for my brain and
Mhm.
my memory. And, there's been some positive correlation between anticholinergics and, like you said, memory loss and dementia. So that kind of terrifies me. So my goal is to hopefully completely get off of it so that I can and then go to the supplement exclusive route. So I don't have to worry about long-term side effects.
Yeah, what amitriptyline can be very good for bladder pain and patients who get up a lot at night, right, and sleep. So it's hard. That is a very it's sort of like walking a tightrope, right? Where, if you don't get a good night's sleep, and that's happened with me when I'm up all night, let's say on a night of call, I'm not as sharp the next day. My memory's just not as sharp. So you need that sleep to be able to have a good, to be, optimize your day and your productivity. But at the same time, we always worry about that. What's sort of like maybe a lower dose, right? Where you take a lower dose of amitriptyline, just enough where you're getting that sleep and getting that pain control.
I did do that. I did go down from 35 to 10. So I'm on a lower dose and have been on a lower dose for a while now. And it's 10 is the lowest dose pretty much that you can take.
Yeah.
You could go 5 if you broke a 10 in half. But, it's just one of those things that I know is it's a long time to be on one drug for over 20 years. So I'm always kind of just, ugh, I just really got to get off of this. But then, of course, like you said, sleep is a very important thing.
Yeah. I
And it's
mean,
hard to
10
find.
milligrams really is a low dose. Like that to me is a very safe dose. When we put patients on, and again, talking about like why we like sort of like why the benefit of supplements, but we often will try to get patients to 50 milligrams. Patients with bad bladder pain, often that phenotype of bladder pain with pain in other body parts, TMJ, back pain, migraine, right? Those patients we try to treat more systemically with amitriptyline, and we often will go up to 50.
Right.
So, and that can be very sedating. So some patients are like, no, I'm good. I'm going to stay on 25. So 10 really is like a nice low dose of that drug. That's like kind of a great balance if you're able to have good control of your symptoms with that. I think that's probably as safe as you get with that drug.
Yeah, that's so I've heard. Um, so what role does stress, trauma, nervous system dysregulation have and play in urgency and bladder conditions in general?
You know, our first line in our American Urologic Association guidelines, the first line treatment is stress management, getting enough rest. Trying, it's easy to say reduce your stress level because you're like, but I got this, right? To do or so it's hard because stress management is not an easy thing. But it's we think that stress does exacerbate symptoms. And I've had patients who are like, "Oh, I was doing so great. Then I had this life event and my symptoms came back." So it really, you don't want to that worrying about stress can actually make your stress worse, right? So
It's a
like,
cycle.
I'm again, as I mentioned, sort of approaching that menopausal age, and I noticed a lot of my hair falling out. I'm like, it's the stress. Oh my God, my hair's falling out. I feel like worrying is not going to be good for my hair, right? I need to like not add more stress by worrying about stress. But again, getting enough rest. If you have the ability to maybe take a day off here or there, that can often be really helpful.
Mhm. I love that they're now implementing, it's been for a while that they're implementing mindfulness programs into the hospitals because that is
Yeah.
so, so important. It's
That's so true. Cognitive behavioral therapy can be very effective. You know,
mhm.
I not for everybody though. Like I had that for my sleep, uh, and I realized what I really needed was a little bit of hormone replacement, and that made a huge difference because I tried so hard with cognitive behavioral therapy. But again, for pain, mindfulness, I think that's really, really helpful. I think the
Mhm.
whole, taking into account the whole patient. It's not just like a pill, but like a whole way of like living to try to help improve pain syndromes.
And do you find that patients that you see who have IC who are taking HRT, is it worsening or helping their symptoms? So I assume
What
atrophy and all those symptoms that come along with perimenopause can exacerbate symptoms. Then there's more recurrent UTIs from the lack of
exactly?
estrogen. So
So
yeah.
we love vaginal estrogen. You know, there's no association with vaginal estrogen and cancer in any part of the body. So vaginal estrogen is great. Um, I don't, that's really great. That's a really important study I think we need to do is looking at hormone replacement on IC symptoms. I'm going to write that down. I have my list of like ideas. We'll make you an
Yeah.
author. We'll make you an author, Marnie. But yeah,
Awesome.
but I think but one thing we do see for sure is in you know, premenopausal women who still have a period, when hormone progesterone drops right before menses, they get a lot of exacerbation in pain. So it's in that around menses. So that does point to a hormonal component. Now, patients who get pain with their period, like bladder pain, pelvic pain, may have endometriosis, but they can also have bladder symptoms exacerbate sort of before menopause, before menses, like when those the progesterones drops. So we I think that's an important point. There is largely or very likely a hormonal component in a lot of patients.
Mhm. If someone's newly diagnosed and they're overwhelmed, what's the one piece of advice that you want them to hear?
I think the important thing is if you have pain, don't panic because pain makes is I've had situations where I was like, you know, my knee was really bothering me. I'm like, I need a new knee right now. I can't live like this. And then the doctor's like, you don't need a new knee. And I'm like, okay, fine. Well, I need a better plan, right? So I think it's important that we will find a plan that helps. And it may take some trial and error. We sometimes need to try a few different things. Um, you know, it doesn't mean you're doomed to be in pain for the rest of your life all the time. Sometimes IC can come and go. Sometimes it can get better on its own. Sometimes it could, you know, wax and wane, get better, get worse, but we can be there for you and help you get through even like flares. So I think that's really important to, you know, help find the right provider and then you'll be able to have your symptoms managed. You know,
Mhm.
in our office, we have physician assistants who help. So if I'm not in the office and a patient needs a bladder installation for pain, they can get treated right away. They can drop off a sample because sometimes patients with IC also have UTIs. So it's often important. We do like to check that urine a lot, you know, frequently.
Mhm. And I think education is so important for people too, because I remember when I was first diagnosed, there wasn't that much out there. You know, now you've got people talking about everything, whether it's through social media, there's specific pages dedicated to conditions. You can do a ton of research. You've got ChatGPT, you've got my resource, you've got lots of options, which is super helpful. And you don't have to feel like you're alone, which is, you know, something that I really felt. And that's why I started doing this in the first place, because it was a very isolating experience. And I wanted people to have a resource where they could come and find the answers and get the support and learn to advocate for themselves. And I think that's the important thing, right? Is being your best advocate because your health is yours. And you guys are there to help us for sure, but we also have to understand what's going on with our own bodies and learn that there's, you know, there's so many components that come into play, the mental piece, the physical piece. Um, and so I thank you for what you do. And I just hope that there's more doctors out there who take the time to educate. And thank you so much for coming on and sharing all this knowledge with everyone.
Well, Marnie, thank you for what you do. I think, like you said, having that support for patients where they can bounce things off of each other, learn from you, learn from this type of you know, interview or interaction, I think is really important.
Mhm. Mhm.
Otherwise, you know, when I have patients who don't really know what they have, it's really scary for patients. And often they think they have bladder cancer, right? So I think getting those resources and that support is so great.
Mhm. And just make sure it's credible, everyone.
Yes,
Right?
yes,
Yeah, because there's too
exactly.
much out there these days, and people are getting mixed messages and false news and all that. So it's important to really know where your content and where you're getting everything from. So it's amazing also that like so many doctors now, and it's great to see that so many doctors now are actually starting to go into supplements and realize the benefits of supplements, which is really special, right? Because we had conventional medicine very separate from holistic medicine, and now there's sort of this merging of the two, which I think people need to realize is sort of the important piece, right? Like piecing together the puzzle. And so the more doctors that are sort of bringing on these holistic opportunities, the better, in my mind.
Oh, that's neat. Yeah, no,
Yeah.
I thank you. I appreciate
Yeah.
that. I think that's
Yeah.
really important.
Yes. All right, so we'll end there. So thank you so much. And I think this is going to be really a great conversation for people to listen to and understand the differences between overactive bladder and IC. And thank you again so much for coming on, and we will talk soon.
Oh, you're the best, Marnie. Thanks so much.